Welcome to Monash University, Malaysia. And more importantly, welcome to the first Sir John Monash lecture of the year for 2018. We do have a series of lectures every year. And for this year, we are honored to have Professor W. Sander for our talk on that's something been, for us, we think that's been much neglected in Malaysia, especially in the clinical research areas. And this is something which is pretty dear to the School of Medicine in Malaysia. Sir John Monash lecture provides an opportunity for our university here, Monash University in Malaysia, to engage with the community, especially in our local area in Selangor in Malaysia, and to engage with also professionals that might be around to come and first to know about our university, other than to start engaging with somebody very specialized topics that we have selected. So Professor W. Sander, he's a professor in neurology. He's a neurologist. He's a physician, a neurologist at University College London, at the Institute of Neurology, and he's also a consultant neurologist. He's also the clinical lead for the epilepsy research in the National Hospital for Neurology and Neurosurgery, Queen Square, London. So we can see everything about neurology is associated with Professor Lee Sander. He also very actively involved in research. So he's the director for the Chalfont Center for Epilepsy in Buckinghamshire, United Kingdom. He's also the R&D director for the Stichting Epilepsy Intelligent Netherlands. I don't think I pronounced that correctly, but it's okay. In Hampstead in the Netherlands. So in actual fact, he just told me he stays in Netherlands and commute between Netherlands and London. So that's amazing. He also heads the World Health Organization Collaborative Research for research and training in neuroscience in London. So there's a WHO headquarters in London that Dr. Lee Sanders is heading. So who is, in terms of his background, he's a medical person, practitioner, trained in the University of Paraná in Curitiba, Brazil. So first thing that comes to my mind, is he Brazilian? He said he's the first generation of immigrants from Germany and Bulgaria. So he's European in actual fact. And then he moved on to United Kingdom, where he did further up his medical training and specialization in neurology in St. Thomas Hospital, and also at the National Hospital in Neurology and Neurosurgery in London. The good thing about him, other than being a neurologist, he's also a scientist. So because he got his PhD in neuroscience from the University of London. And that's why, for the next description that I'm going to do is amazing for a clinician. This is in the context of being a clinician and a scientist. He has published 650 publications. And that's pretty huge for a clinician. Usually they are so busy at attending to the patient and got no time for research, but he's one that can do both, so it's really amazing. And obviously with that amount of publication, he got 32,000 citations. That's huge. For a scientist, a lot of work that has been done, being cited, is of great importance, and that's why it's been cited. And I think that's a very important. And also a huge H index. For people in research, H index is an indicator of your research performance. So he got H index is 96. I think that's really amazing, and I salute you as a researcher. You've done really well. He's also the elected fellow of the Royal College of Physicians and a member of many of the learned societies, especially the professional bodies in the medical line in neurology, and including the Royal Society of Medicine, Association of the British Neurologists, American Academy of Neurology, and the British, Dutch, Swiss, and US chapters of the International League Against Epilepsy. I think he is the champion for epilepsy, and we are really honored and privileged to have him today. And without further ado, I'd like to invite him to present his topic today, Comorbidities and Epilepsy. What are they telling us? Thank you.
To talk about something I really enjoy to do, to talk about epilepsy. Most of my research career has been in this condition. I'm a neurologist by training, but I have been involved since the time I was a medical student into epilepsy. It's a very sort of interesting story that got me into epilepsy was when I was working as a paramedic just to increase my grant or to get by. One of the first experiences I have as a paramedic was to come across a person with epilepsy. And I had no idea what to do, and I was completely overwhelmed by the seizure I saw. And since that day, I decided that I wanted to do something for epilepsy. But epilepsy is not really a disease, and it's really just a symptom, just like anemia. And this is a little bit of a problem, and that causes a lot of challenges, and I will try to tell you a little bit about this. I'm very honored as well to be able to give a talk with the name of Sir John Monash, who I think is one of the most interesting persons I have come across. Actually, he was everything. When I looking through and trying to look him up, I found out that he was a very accomplished pianist. He was a lawyer. He was a soldier. He was actually the top commander of the Australian troops in World War I, a general, yeah? And he was actually the first Australian-born commander of the Australian Army. So he was an educator, he wrote a lot, he was a lawyer, a patent lawyer. He made his fortune from his inventions, getting IP at the time. But he was always a very clever guy in the sense that he placed everything in the context. And he would always say, whatever you do, you need to do for the benefit of the community. So I think that this is quite an admirable thing. And I'm very proud to be able to one day present this lecture. So many thanks for this honor. What I'm going to talk and discuss with you today basically go through the comorbidities of epilepsy because I believe they're telling us something. Before I move into this, I want to tell you briefly what is epilepsy, the burden that epilepsy represents to the individual, to society. I will discuss the flawed current paradigm of treatment that we have, talk a little bit about prognosis, talk about the comorbidities, and then try to tell you what I see as the next big change, the incoming shift of the paradigm we will have in medicine with the genomic revolution hitting the ground, and tell you a little bit about how I see the future of epilepsy and neurology. Epilepsy, it's the commonest serious neurological condition, and it affects at least 60 million people worldwide, probably more like 70 million. No one knows because we will never know the magic number, but it's well into the 60 millions. It knows no racial or geographic barriers. It affects people in all levels of life, any ages. It's a highly stigmatized condition. It doesn't matter where you are, epilepsy is stigmatized. And this is quite different from most of other neurological conditions. People don't have any problems to go along and say they have Parkinson, but a lot of people will have issues to say they have epilepsy. It has this very high comorbidity that goes with it, to the extent that when someone has epilepsy, you should be asking, epilepsy and what else? It has a very high risk of premature mortality. This is one of the important parts of the burden it imposes in the individual and on society. So as I said, we need to fully understand the fact that we're not talking here about a disease. We're talking about a symptom complex. Epilepsy is the tendency to have unprovoked seizures. And there are many, many, many causes and risk factors for that. And the last account, there have been more than 400 different either genetic or other conditions that have been associated as triggers or causing epilepsy. It's basically the result of an underlying problem of the brain, but the comorbidities are probably telling us that this might be also a system problem. It's not just the brain. It's more than just the brain. Many of my colleagues often talk about maybe because some similarities on the fact that they're chronic conditions and similarity in numbers that, compare epilepsy with diabetes. But that's not correct because we know most of the time as the physiopathology of diabetes. Epilepsy is more analogous to anemia, where there are hundreds of different causes for anemia. But in the eyes of many, including many neurologists, epilepsy is seen as a disease and, people have this problem. And this is, in my eyes, an issue. It is more than just yet another disease. And I think that part of what this causes is the burden of epilepsy. Epilepsy, as I said, is viewed as a stigmatized condition, viewed with fear. It's associated with a lot of superstition and misunderstandings. It's an interesting condition in the fact that most of the time it is not there. It's only when someone has a seizure. So someone has 2 seizures in a year lasting 2 to 3 minutes, and 99.9% of the time they don't have anything. But that 2 to 3 minutes twice a year may lead to a life of stigmatization. And I think that it's important that we realize that for a lot of people with epilepsy, the stigma causes more problem than the physical issues that epilepsy brings. We need to sort of understand that and take this into account. But the stigma is not the only burden that epilepsy imposes. We have many burdens. We could talk about the individual stigma, as I said, the individual burden that the stigma brings on, the demographic burden of epilepsy, which used to be a condition that was said to be always started in the pediatric age group, but nowadays the group in the population with the highest incidence is the senior citizens. It's actually a condition of both ends of life. We have a sort of bimodal, we have a peak in the first years of life, and then a peak once people go over the age of 60. We have the social burden. We have also an economic burden because epilepsy tends to drag down people. As soon as you have epilepsy, it's very difficult to get work. And if you're qualified, you might not get a work which is compatible with your qualification because people are not prepared to take someone unless they take lower status jobs. We have this lack of knowledge burden. And this is something that really, really bothered me because I like to think myself as a scientist, but often when I treat people with epilepsy, I'm no better than a shaman. Handling out, dishing out medications that I'm not quite sure if they're going to work, and we do not understand the evidence. So this is really part of what I call the lack of knowledge. And we have a lack of resource burden. Epilepsy is not a priority. It's not just in Malaysia. In most countries of the world, epilepsy is not considered a burden because, as someone has a fit here and there and that's it. But it's not just like that. It's much more than that. Some of you might not be familiar with the concept of what is called DALYs. That's disability adjusted life years. Is a measure to how a disability or a condition imposes in society. And if we looked at neurological conditions, we will see that all the neurological conditions in terms of the burden they bring in is about 74 of these disability adjusted life years. But a quarter of them are from epilepsy. So the burden for epilepsy to society is much bigger than MS, is much bigger than Parkinson's disease or Alzheimer. And part of this, you could argue that many people have epilepsy for 20, 30 years, while someone with Alzheimer, once they have the diagnosis to the time of the demise, it's 7, 8, 9 years. This is part of why we have this big economic burden. And I think that it's very important that we remember epilepsy affects more likely people of lower economical strata of society. Places of resource-poor places have more epilepsy. There's a number of reasons that might explain this. It's likely to be multifactorial. Infections, environment, associative mating. In some societies where people have weddings, people might not be able to wed into a family or might not be able to wed because they have epilepsy, so they tend to have, they go together with another family that have epilepsy, and this can bring some issues. And epilepsy has a dragging down effect that I already mentioned. So it really brings in a huge economic burden. In the UK, epilepsy is about 1% of the hospital cost. Often it's when people end up in casualty because they had a seizure. They need to have imaging. They need to have some tests. They cost, in terms of drugs, £15 billion a year. And in terms of cost of illness, this is direct cost of illness, estimated from the States and from the US, and these are old data, and this was when drugs were much cheaper. So, this is likely to be more expensive because what we see nowadays, when yet another new drug comes out, it looks like the one thing you can say is unlikely to work and the price is higher than the previous one. So I think that if someone was going to set up to do a cost of illness, this would be much higher than the 15 billion euros that was found for Europe in 2004, or the over 15 billion each year in the US of direct medical cost of this condition. Now, the lack of resources burden. And we, for who were here yesterday, we touched upon this, and sorry that I'm repeating myself. But if you are in a public health agency or if you're a granting agency, you tend to find priorities. And in many countries, the threshold in terms of prevalence for a condition to be considered a priority, it's going to be over 2.5%. Because epilepsy has a prevalence of no more than 1%, in most places this is not considered a priority. Furthermore, it's not perceived to be, it's seen as a benign condition, which is not. And therefore, it's not really a priority. And this is the same in almost every country with a few exceptions. Now, I always say, if someone has epilepsy, it's most likely that they will have a pair of parents. They might have a couple of siblings, some relatives. So the indirect prevalence of epilepsy is much higher than the 1%. And there's very good data to suggest that having someone in the family that has epilepsy has a big impact, more than other chronic disease. So it's very important that we remember that there's also this sort of indirect prevalence that is not taken into account. So we have this low priority. And the other problem is that it seems that all societies, most countries, the resources seem to be going down, particularly for health. That's the case in most European countries. That's very much the case in the US. And we heard, for instance, that the NIH is losing almost a third of its budget. So we can hear this. So, when you have decreasing resources and a condition that's not a priority, you can see things not getting better. But the costs keep going up. Every time we see a new anti-epileptic drug, it looks like it's doubling the price and so on. This is another problem. I mentioned this. This is the lack of knowledge. We don't know who will develop epilepsy, who it will strike and when. We have no risk factors, but even when we have a risk factor that is highly associated with epilepsy, we don't really know if this person will have it. For instance, severe head injury at 10 years after, 50% will have epilepsy, but 50% don't. We don't know who are going to be who. If someone has epilepsy, we cannot work out the outcomes easily. It's actually one of the things that is very frustrating if you're a clinician. And as I said, using drugs is a frustrating experience because you don't know which, when, and why it will work. And most of the time we shoot in the dark in the hope it will work. This is really, I put my hands up. And outcomes in any given person at the onset is very much a guesswork. And the janitor of the hospital, someone in the street, the parent, the patient, or my guess is going to be as good as any. So what contributes to the risk of epilepsy in a person? We know that when I see someone with epilepsy, I will try and find out the age, where they come from, the ethnic group, where they've been, because there are a number of environmental risk factors for epilepsy. So for instance, worldwide, the commonest risk factor for epilepsy is a tapeworm called Taenia solium, which actually is probably responsible for between 10 and 20 million of the cases of epilepsy. And this worm is endemic in some parts of the world. So if someone comes from parts of India, some from the Punjab, for instance, someone coming from the west coast of Latin America or west coast of Africa, Madagascar, I'm going to be thinking highly in neurocystic psychosis. But of course, someone had a brain infection. That's also going to be taken into account. But it's a sort of puzzle try to get together. And 80% of the time we can get near there, but not always. As I said, 1 in 5, we are not the wiser. Now, the last burden which I see is the lack of personalized treatment. Actually, when I treat someone, the best I can do is I shoot in the dark. 50% of the time it works, but I do this blindly. If I try the second drug, and I will come back to this is very frustrating. And we have clearly this law of decreasing returns when it comes to treatment. And I hope that before I go, we really have proper treatment. We are treating the condition and not trying to control seizures. That's a big difference between the two. So I would like to actually see personalized treatment. So when someone comes to see me, I would be able to say, this is what is causing your epilepsy, and we need to use this to do something for it. I mentioned earlier that it's often seen, particularly by public health planners, some general physicians, granting agencies, as a benign condition. But this is far from the truth. Epilepsy is a very malignant condition. The standardized mortality rates for epilepsy are very high. And if you look in resource-poor countries, it's much higher. So for instance, there's good data that has been consistently confirmed in different parts of China that if you're in rural China and you develop epilepsy, you are more than 20 times more likely to die earlier than you should. So this itself is a big problem. This is not a benign condition. But until recently, we would always thinking, hey, wow, this is to do with the seizures. If we stop the seizures because people may have a seizure in the wrong place at the wrong time and come to harm. We stop the seizures, everyone has the same life expectancy. So it's very shocking to see that even when epilepsy is fully controlled and when seizures or not even drugs around, the life expectancy of people with epilepsy still slightly reduce. And this in itself is a public political statement for something that we have not fully worked out. What is this telling us? And I think that probably the fact that this premature mortality is independent of seizures is probably telling us about comorbidities that may come with epilepsy. So I mentioned already the treatment, and I'm not going to spend too much time with this. I just want to tell you what I think about the current treatment paradigm. This is one of the most flawed problems, big issues we have. This is a disaster. This makes me think that I'm no better than a shaman when I'm treating someone with epilepsy. And we look over time, whatever substance that has gone down the gullet of humans has been used for the treatment of epilepsy. And not only that, but also from sacrifice, trepanations, bleedings, purgative diets, hysterectomies, all sorts of, you think about it, it has been used, I can guarantee. There's fascinating reading about what has been used over the years for the treatment of epilepsy. Of course, we have a surgery for some types of epilepsy, and that's probably the most rational treatment we have. Because for the right person, sometimes surgical treatment can be curative. But unfortunately, this is only a very small percent, very small part of the number of people with epilepsy. It's a treatment that can only be used in 2 to 3% of people. For the majority of people, we talk about drugs. So anti-epileptic drugs are the mainstay of treatment. And as I said, the non-pharmacological treatments, they only apply to very small percents of the population. Surgery, no more than 3%. If we talk about ketogenic diet, it's a very small number of people. And there are now some biomarkers for people that respond to the diet. For instance, the kids that have the best outcome with this diet, they have a deficiency on a gene that helps sugar get into the brain. So they cannot actually get sugar through the brain barrier. But you know, the brain can also work on fat. Sort of some engines might work on diesel. So if we could get people a very high fat diet, that will provide energy to the brain. So for some people, the ketogenic diet can be amazingly, and it works. And who remembers the film with Meryl Streep some years ago, 30 years ago, and then everyone wanted to have the ketogenic diet? The kid, her daughter, probably had GLUT-A deficiency because she responded so well to this treatment. So it's not a treatment that we would dismiss, but it only works for a very few persons. If we move on, look at the number of drugs we have for epilepsy. You know, often when I talk to colleagues outside the epilepsy arena, they will say, God, how many drugs? Are you a homeopath? Because, you know, there's very few therapeutic areas that we have so many drugs. But despite having had an explosion of new drugs in the last 30 years, the outcomes have not really changed. So when I started in epilepsy, we would say about 30% of people do not respond to treatments. What do I tell my students these days? About 30% do not respond to treatments. But despite this explosion of drugs that we had in the last 30 years, it has not really made a big difference in the outcomes. For some individuals, some new drugs have been wonderful and very good, and it's very gratifying. But for the group as a whole, epilepsy drugs, the new ones, have not had the impact that we were hoping. So why is this? It's because we have this flawed treatment paradigm. It's symptomatic, treat seizures and not the epilepsy. So we are trying to control the symptom seizures and not really trying to treat the whatever is causing the epilepsy. So it's not really rational. It's empirical. Because we say, hey, little Johnny, in my experience, for your type of epilepsy, this drug seems to work better than others. I don't really say, little Johnny, you have a problem with the sodium channels in your brain cells, and we need to use a drug that is going to actually modify your sodium channels and so provide the treatment. That's not how it works. Unfortunately, this is an empirical approach, and my blood boils when I heard some of my colleagues going around the world telling people that we have rational treatments and even we have rational polytherapy. That's a big nonsense. As a result of this, we shoot in the dark and hope it works. And there's nothing wrong with empirical approach if it works. I don't want to know what it is, but it worked, everyone will be happy. So before I go, I really would like to see curative person treatment that really is going to modify the disease, not just controlling the symptoms. But what we have in epilepsy, can you imagine if you were we treat epilepsy blindly. So the first drug seems to work in 50% of people, and people that the first drug doesn't work, another 50% the second drug works. But after that, it becomes very difficult. So if you were to treat anemia blindly, and you use iron sulfate as the first drug, probably 50% would get better. If it didn't work, let's try then folic acid. You would get some more better. Let's try B12. Let's try this and that. And every drug you use, you're reducing, and then at the end, it's going to be very difficult. For some people with anemia, an anthelmintic drug may work, or maybe surgery may work if they have a very severe bleeding from somewhere. So, surgery could really help some people. So we have this law of decreasing returns. And it's very important that we actually accept and we discuss this. Otherwise, everyone is going to be frustrated, particularly the patient and the physicians. I mentioned to you that about a third of people have refractory epilepsy to the current drugs. And despite the increase in the number of drugs, this number does not seem to have changed dramatically. We know, for instance, that people that have partial epilepsy, that starts in a localized area of the brain, people that have more than one seizure type, people that have other problems, neurological problems, people that have a long duration, people that have great number of seizures at the onset, they are the ones that tend to do worse. But these seem to be markers for a bad outcome. But we really cannot guess in any individual, because sometimes we see people that have more than 2 or 3 of these and they still do well, maybe 5% do well on a new drug. Sort of chronic epilepsy, it's very difficult to define. And I could discuss this for days and we wouldn't get to a conclusion. But if someone has active epilepsy of 2 years after the onset, regardless of the drugs, they will have epilepsy 5-10 years later. If they fail 2 drugs, the chance of them having epilepsy 5 or 10 years later is still great. And if someone has more than 10 seizures in the first 6 months, they're likely to have seizures 5-10 years later. But I think it's very important that we remember, before we declare someone having chronic epilepsy, we need to work out that they do not have what I call pseudochronicity. This is people not having epilepsy, which is common. Misdiagnosis is probably about 20% in Europe. We have the issue of people having the wrong type of drug for some epileptic syndromes. They might get worse. And we have this other problem, people not taking the tablets. You need to remember that if you're controlling the problem and not having seizures, the only reminder of the problem is taking the tablets. So it's very easy to forget to take the tablets, particularly when there is a change in routine or something happens. So not taking the tablets is a big reason why people carry on having seizures. And these doctors often do not take this into account. Now, moving on quickly to tell you a little bit about the comorbidities of epilepsy. Until recently, we spoke a lot about the psychiatric comorbidities, cognitive. But nowadays, the somatic comorbidities are coming to the forefront. And we're seeing a number of things being identified. Part of this end result are the big data. You have huge databases where you can mine. Because, if you're a doctor in a big clinic, the number of people with rare condition is going to still be small. So you cannot see if, in your clinic, people with epilepsy have more than they should have Crohn's disease or more than they should this type of diabetes or that. So once you have big databases, you are able to pick up some of these comorbidities. Now, I mentioned already that when you see someone with epilepsy, the first question always is it epilepsy? And the first mantra is this one: is it epilepsy? And if you look into this, you will see that misdiagnosis is rife. Over 50% of people been diagnosed at primary care as having epilepsy. Once they are reviewed and the secondary care clearly they don't have epilepsy. And you know, if you have an event, for instance, people that have a faint, they don't read a book. So they can wet themselves. They can bite the side of their tongue. Yeah, they can have some jerks. But the books say that if you have a faint, you will never wet yourself. But if you're running to the toilet with a full bladder and you have a faint, you're going to wet yourself. So if someone has a faint, the mother sees the kid for the first time having a faint wetting themselves. Or even little poodle can become a big puddle. So at the heat of the moment. So the GP, we shouldn't be blaming primary care because they are right there at the heat of the moment. If you're in the hospital a week later, you get a less jaundice story, more realistic. And then you can actually do this. But in the other end of the spectrum, in terms of chronic epilepsy, it's very consistent. And this is the same in the Netherlands and Germany and the UK where you have looked this. There is data coming out from Japan. About 1 in 5 people have been diagnosed with chronic epilepsy. They don't have epilepsy. Some of these people might have had seizures in the past. Then people may learn the secondary gains they can get and they will carry on having seizures. So a careful diagnostic assessment is a need at any point. And you need to remember, this is dynamic. Someone might have had seizures today, and now in the UK there's been a major change in the benefits. So people with epilepsy would get benefits, but nowadays they don't get it anymore unless they're having seizures. So what's happening, you're seeing a lot of people suddenly been taken off their benefits. So of course, I think it's quite practical solution is to start having seizures again until they get their benefits. So you need to be really aware of the sort of things that's going on because most of the time it's not there. If you tell your benefit people, my seizures are back, you cannot actually carry on checking all the time. So it's very important that you remember that you should always doing this. Now, we have this very high prevalence of comorbidity. They're a very important part of the burden because they affect quality of life. They increase utilization of health service, the financial cost, they complicate management, and they probably have a role in premature mortality. And this seems to be independent of seizure activity. The CDC in the United States have shown that comorbidity is much higher in people off drugs and with those seizures, just having had an history of epilepsy. And why this is, I don't know, but it's probably telling us something about maybe genetic predisposition. So why are so many comorbidities associated? Well, some of them might be just random. They could be chance. Someone might have an accident and have something that goes wrong just by chance. But some of them, the same thing that is causing the epilepsy could cause another problem. Someone has a head injury, ends up with an hemiplegia and has epilepsy. So the same causal mechanism is causing both. We might have a situation that someone has a seizure and will break their arm because they have a weak bone because of the antiepileptic drugs they're taking. So, you can have a resultant comorbidity. But more likely, we have shared risk factors. For instance, the same risk factor can actually increase the chance of epilepsy comorbidities. And I will mention a few of them. For instance, if you have diabetes type 1, you're more likely than other people in the community to develop a specific type of epilepsy, which we call idiopathic generalized epilepsy in the old classification, and it's bidirectional. So this must be telling us something. Both conditions, by the way, they have in common high antibody levels. What this is telling us needs to be fully worked out, but it's very, very interesting. And as I said earlier, and I will keep insisting, they're probably telling us something and we should work out. So this high rate of psychiatric and somatic comorbidities, they bring in the second mantra. If you're happy someone has epilepsy, the next question, epilepsy and what else? Because once you systematically start to try and find comorbidities, 90% of people attending hospital will have something else. And we are only interested in the seizures. So we tend to not be very interested if they have another problem. And this is part of the approach we have in medicine these days, which is really disjoint. So I already mentioned diabetes, systemic autoimmune disease are now making the rounds as some common comorbidities with a bidirectional risk with epilepsy. And I'm not even going to go into many details on psychiatric disorders because they have a very high incidence of anxiety, depression, personality disorders, psychosis amongst people with epilepsy when you compare them with the general population. All the numbers are increased. So in terms of implications for current practice, epilepsy should increase the suspicion of other disorders present, and we should be actively screening for other problems. And we need to take this into account in providing a person-centered treatment. they should be part of our phenotypic stratifications because they're telling us something in terms of common mechanisms. And I think that they will probably help in terms of trying to understand common genetic predisposition. So this is one of the reasons for this. Now I'm going to spend the last 10 minutes incoming paradigm shift in epilepsy. And I think it's very important that we remember that in epilepsy we have not had a paradigm shift for over 100 years. This is actually shocking. On average, a paradigm shift comes in every 40, 50 years. In epilepsy, we have gone well over 100. And the last big paradigm shift was with a guy called Ewing Jackson, who actually gave the sort of first understanding of epilepsy being a brain disorder. And this paradigm shift should not be seen as a bad thing. It will probably help us to improve the lot of people with epilepsy. The big conceptual breakthrough is that epilepsy is always a symptom. And every time that someone has a seizure, there is a genetic contribution. That should not be a surprise. But we need to take into account that genetic does not mean always inherited. Actually, it is the exception when things are inherited. Most genetic conditions are de novo. They actually start on that person. So we have probably less than 20% of genetic epilepsies, they are inherited. Most of them are de novo. And it's very likely that we will find out that epilepsy is not just a brain problem, but a system problem, and it's part of a spectrum. And I will come back to this. If we could apply this properly, what we are starting to understand from genomics, this will really lead to an improvement in care because we should be able to understand better the causes, the diagnosis, the prognosis, how to treat. We could, for instance, identify, as we discussed yesterday, people at risk for SUDEP. And this would all lead to better and personalized treatments. Now, is it a surprise that there is this genetic contribution? No, it shouldn't. Epilepsy is just a neurological condition that's characterized by this tendency to have seizures. But then life really is a genetic disease, sexually transmitted with 100% fatality. So it should not be really seen as a surprise that the genes are playing a big role. But we need to understand, again, as I said earlier, genetic doesn't mean to be inherited. It's just part of our blueprint. So epilepsy, it's likely in the future to be part of a spectrum of conditions that come and go, like, for instance, depression, migraine, but also a number of other conditions that nowadays are under the realm of psychiatry, some of them under the realm, for instance, of general physicians, like cerebral vascular disease, some autosomic immune disorders. I mentioned already diabetes. And in the future, we will be talking about the functional spectrum. Neurology will change behind recognition from what we're talking nowadays from our current paradigm, which is disease-orientated. We talk about Parkinson, we talk about Alzheimer. But basically, what we need to remember is that what happens with a disease is very much dependent on the stage of your brain development. So we will have disease associated with the developing brain that goes until about 7 years. We have the maturing brain that goes until we stop growing. We have quiescent brain that goes until the end of our 20s. And from there on, everything is downhill with a degenerating brain. But we have a number of spectrum of disorders. You know, you have a trauma, you put your head in the wrong place at the wrong time. You might end up with a head injury that might lead to inflammation, might lead to a number of things. So we have a number of these spectrum. Sometimes you might have just, subnutrition, or you might have a metabolic challenge. And at the end is our genetic blueprint, the genome. So the interactions between these matrices will lead to what our brain will have in terms of the disorder. There will be multiple overlap between these spectrums. So in 10 years from now, it's very likely that the boundaries between neurology and psychiatry will be decreased, because a lot of the conditions that are nowadays classified as psychiatry will be part of the same spectrum, and they're likely to come together again. So I can see this. Epilepsy, the vision is that we will move away from this disease concept and we will accept this as a symptom complex, part of a collection of many different conditions, many neurological conditions, usually very rare and very individual. And we will be probably using genetic assessment much earlier part of the clinical phenotyping. And this will have implications in terms of cost, in terms of taking this forward. So epilepsy, as a collection of rare disease within a spectrum is already happening. We wouldn't have heard about Dravet syndrome 10 years ago. We wouldn't hear about heterotopias. We wouldn't hear about dysplasias. We wouldn't hear about a number of conditions that are now fragmenting out what used to be epilepsy. And this is the way that it's going to be in the future. So we need to get ready for this. We really need to make a move toward getting ready so we can actually provide the best treatment to all people with this condition. So the challenges ahead for the physicians and for the epilepsy community to ameliorate the burden, so we need to characterize the spectrum in full. We need to understand why each person has epilepsy. We need to understand this genetic contribution, and we should be deploying genetics as a powerful clinical tool. And I think it's very important that we remember that genetics is no more than a tool. It's not really a hocus pocus it's a tool like an MRI, like an EEG. We need to actually put this together in the context of the clinical presentation of a person and then try to work out in terms of trying to get the personalized treatment that will make a difference. So no one is wasting time. We can treat someone from day one rather than sometimes shoot in the dark for years before we get the right treatment. I think that the future is now. The genome revolution is starting. We have our first 1,300 patients had genome-wide scans. We still do not understand what it means, but we are trying to put it together. And I'm sure that we will see a lot of changes. And we will know and we will look back in 10 years' time how primitive we were in the treatment and the way that we handle epilepsy until now. And I hope that my foresight is going to realize before I go. Thank you very much for listening.
Thank you. Thank you so much, Professor Sander. There we have it, mainly from the clinical point of view and from the scientific point of view perspective. And we thought we know it all, but you can see there's a lot more questions and answers and a lot of things that we still don't know. It's really amazing after doing the research with 600 over publications, there's a lot of more knowledge and no findings need to be done, especially in the field because there's still a huge unknown. And I think one of the areas in which Prof Sander mentioned very strongly is the pharmacogenomics area that needs to be really explored in terms of having a very specific medication for individuals based on their genomic contents. So that is being done a lot, I think, but not much success in terms of application yet, because a lot of people are not able to or not wanting to reveal their genomic content per se, so that that can be used or to let everybody knows this is my genetic constituent. And then you can actually now sort of know me everything about who I am and what I am. I think that's a very important context. So now the floor is open for us to have all the questions that might be coming in from the presentation and beyond that. And I think Prof Sander has been pretty provocative in many ways in terms of the content, where do we go for the future. And the future is now. And the future actually, what I can see, is full of challenges. Thank you. Okay, any questions, please?
Just two short questions. Number one, what research is there on, say, correlations between brain tumors and epilepsy? Number one. And number two, what treatments, shall we say, what research has there been so far into treating epilepsy rather than just treating the symptoms?
We know that brain tumors are highly associated with epilepsy, particularly slow-growing tumors. The reason that this is, it's not well known. Part of this could be the edema and pushing away and actually pressure on brain cells. But, I think that that's very simplistic. More needs to be done. In terms of personalized treatments, the treatment for the right person, there's a lot of research ongoing. But unfortunately, there's not really made big progress so far. We can say a few things that pharmacogenetics have made a difference. For instance, there's a very disabling condition which actually is fatal in a number of people. It's more common in Malaysia and in Asia than in Caucasians, which is a skin eruption as a result of treatment with aromatic antiepileptic drugs like carbamazepine. We have now identified genetic markers for that. So there's work here in Malaysia, we heard yesterday about it, that you can actually do a test and identify people that are at high risk. Because, if you try that and this person has one of these conditions, it's a disaster for everyone. So that's a very small progress in the right direction. For instance, we know if someone has a specific type of Dravet syndrome, we can treat with a drug called stereopental, and they get much better. And other types of Dravet where there is associated with a mutation on a sodium channel, we know which drugs to avoid, and sometimes we can improve things. And as I mentioned yesterday, sometimes you come across a genetic marker for something like I had 2 boys that were brothers who had very severe epilepsy. And one of the early genomic tests, we found out that they had a deficiency on a gene that deals with creatinine. And they could not really produce creatinine. So they're now seizure-free, completely seizure-free of any anti-epileptic drugs and getting what is called a food supplement for high-impact athletes that they get from the health shop. So much cheaper than. So for these 2 patients, this is personalized treatment. But this is the exceptions rather than the rule. There's a big European group consortium called EPPGX, which is trying to understand and progress more in this in terms of getting personalized treatment. There's a big effort going on in the United States. My fear, and if you remember my slides where I mentioned that it's going to be a very individual thing, it will be that we probably will need so many drugs. We might reposition drugs that already exist. We have massive databases of drugs. But we might create some drugs, and sometimes really getting creatinine out of the health shop could help some people. So I think that the next 5 to 7 years are going to start seeing really moves in this direction in terms of identifying markers for benefit, but also for hazards, to avoid side effects. Because when you treat someone with a drug, you need to make sure that you're not going to harm the person. And if someone has one of these Steve Johnson syndromes, that's terrible. So you can actually then do some good by avoiding these drugs. Things are much slower than they should be. In 1993, when pharmacogenomics started to come out, there is a magazine in the US called US News and World Report. They had a cover which actually was, and they had epilepsy there. This drug is for you. And they were basically implying that in 1999, everyone would be treated with a proper drug. The problem is that things turn out to be not as simplistic and people had then imagined. The hurdles were more than. So we are lagging behind, but real progress is starting to be made. And I think that, as I said, the next 5 years we'll see quite a lot of move. And before I retire, I want to see where I can actually treat someone with a drug that is going to work for them from day one, rather than this really depressing, frustrating way that we do it. We dish out all these poisons not knowing if it's going to work. And it's trial and error. And I want to be the first to move away from that.
In the same vein, Professor Sander, epilepsy and stroke, how is the relationship, and which one is precedent to the other, so to speak, in terms of what you were talking before? And what do you see happening? You've been talking about that we're at the threshold of a new wave in terms of genomics and big data. Can you talk to us a bit more about that?
Yeah.
Because I think that's significant.
The group in the population nowadays with the highest incidence of epilepsy is the elderly. And the major cause, 2/3 of epilepsy in the elderly is driven by a cerebrovascular disease. If you're well attuned with epidemiology, you will know that the incidence of stroke has gone down by more than 50% in the last 30 years. At the same time, we saw this shift from epilepsy moving out of the young age, although it's still a high, and towards the elderly. And what probably happened in terms of this demographic shift is that kids are expectant mothers are leading a more healthy lifestyle. Less drugs, less challenges, and therefore less developing brain problems, less cortical dysplasias, less other problems that have been associated with epilepsy. In the elderly, it is clearly driven by cerebrovascular disease. So a person that 10 years ago would have had a major stroke, nowadays the stroke is very small and the result is epilepsy. The thing about epilepsy in people with cerebrovascular disease as a result of the stroke, that's the easiest to treat epilepsy because it looks like that a sniff of any epilepsy drug seems to work. So that's the good thing. Now moving to the second part, I think that the big data, and whoever was here yesterday will remember that I really think that this will be a major way to change things. For instance, we know that these clustering of some disease, but if you have a disease that only happened 1 in 10,000, in my clinic we are quite a large number of neurologists looking after epilepsy, 16,000 people. So if we have a condition that has an incidence of 1 in 10,000, having at least one patient like this, we would need to have at least 30,000. It's like a rare side effect. A side effect that affects 1 in 3,000 people won't be picked up by a clinical trial program, because that usually involves no more than 1,800, 2,000 people. So for you to be able to pick up something with that incidence, you would have to have exposed 12,000 people to have had 95% chance of having picked up a case. So big data allow us, if we have ways of integrating, let's say my 16,000 patients, plus let's say 10,000 from a clinic in Australia, 10,000 in a clinic in France put together, and we had a common denominator in terms of what we enter in the database. Because, as I said yesterday, we put a lot of things into our database because we are looking for one to be able to explore the big data to help us to identify clusters, associations. For instance, we use 3D photography as part of our phenotyping. So when someone comes in, we will do a 3D photography, and it's fascinating how many people, if you see someone with Down syndrome, most of you will be able to diagnose. You don't have to be a doctor, because the dysmorphism and the face of the person, they're usually diagnostic to some extent. You need to confirm it, but you know where to look. We only pick up dysmorphisms when their symmetry is more than 25%, let's say. So these databases, they can actually sometimes pick up some of these dysmorphisms or asymmetries at a much lower level. If you do it, for instance, you take 1,000 points in the face and you compare, then you can find clusterings. And everyone with Down syndrome, if you put it through this, will appear right in the same spot. So you can actually pick up a number of syndromes using that. So if you have that, I won't resolve this with my 16,000 patients. I need more and more, I need big data to be able to find associations. For instance, if we find this specific dysmorphism, which we cannot see, is an indicator that something goes there and that could help us to phenotype. For instance, we could use, again, we would need big data to even understand if this is something of interest. We could look at the thickening of the retina. Does it change over time? Is this a marker? Does it progress? If we pick up differences over time with people, what is this telling us? So there's a number of things that we could put into this big data that would help us to identify problems, risk factors, and ideal treatments. So I'm a big believer in big data. It has to be done in a proper way. I think that it's very important that we always remember the issues of privacy. In many countries, as soon as you put down that you had a genetic test, your insurance goes up. This is the sort of things that you need to really try to put into your equation. But big data will help. You could say that if we all have an app that is measuring our heart, and if people pick up some very interesting rhythms that are an indicator that you might be at a higher risk of a stroke, and that's only, you need to have 1 million people to see this. You can see that we won't be able to do this in all the hospitals of Malaysia. You might have to have hospitals not only in the whole region, and eventually you can get there. So I see a future for that. I'm a believer. We're making sure that our databases are compliant with everything in terms of privacy, but we also want to include as much as we can. And at the moment we are consenting our patients. I have hardly ever seen someone refusing, but I know that I probably won't see all the results that it could provide. But we need to work that way. Yeah. There is already artificial intelligence, machine learning. It's been used in some areas. For instance, anticipating retinopathy in people with diabetes. Google DeepMind, which is a Google division, is looking into this. Picking up changes in blood screens and blood tests to see if there are indicators that could indicate a metabolic problem. So this is happening. And I think that this has been applied in areas like imaging. People are trying to look at early signs of Alzheimer, Parkinson. And I think that we will have a complete different picture once this is really going at full speed, once we can change the gear.
I have two questions here. Can you actually explain more on the correlation between autism and epilepsy? Because as we know, actually 30% of these autism patients, they are presented with some epilepsy symptoms. And sometimes the autism symptom per se is not because of the autism, but because of the epilepsy. So second question is, do you think that it's wise for us to subject all our patients to do this 24-hour EEG rather than the conventional EEG, which actually lasted only 20 to 40 minutes? Okay, thank you.
Yeah, no, I know exactly what you mean. There is a very high comorbidity, and the more severe the autism, the higher is the epilepsy. Autism and epilepsy probably share a number of things. They're probably part of the same spectrum. Very likely that you have a wiring problem with autism. The same applies to schizophrenia, to other conditions. How do we do it to identify? Are they part and parcel of the same problem? If you ask me, I think we shouldn't be calling this as autism, this is epilepsy. We should calling little Johnny has this condition which presents with this and sometimes has seizures. So this is how to do it. Now, EEG, in my view, in 10 years' time, EEG will be something that we look back and said, do we really use that? And I think when you see that we will have genetic diagnostic, we won't need the EEG. Because, someone comes to me and tells me a typical history of juvenile myoclonic epilepsy, I will get an EEG to confirm this. But if I had a marker for that, I wouldn't do an EEG. See what I mean? But my personal view is that if I'm going to do an EEG and the person is able to tolerate, 24 hours window into brain working is much better than at 20 minutes. Of course, if the person does not tolerate, which is often the case in some people with autism, 20 minutes is profit. But ideally, I think that, it's a waste of time, routine EEGs, because, a 20 minutes window and brain functioning is very little. You really need a much bigger window.
If there is no family history of epilepsy, but there are two siblings in the same family have epilepsy, so is there any research done on this? At what percentage are such cases available throughout the world?
Yeah.
That's my first question. Second one is, I see that there's correlation between epilepsy, depression, anxiety, and you had a long list there. Is it because of the condition itself, or are these additional conditions, like depression and all, are the side effects of the drugs that an epileptic patient is taking? Last is, oftentimes we hear that the clinical neurologist, despite knowing that the patient is doing very well with one particular drug, and if the patient has epilepsy, for example, if the patient only has twice a year kind of epileptic incidences, but they have been treated for the past couple of years with one particular drug, for example, Rapilium chrono, but when depression comes into the patient, why oftentimes the clinical neurologist actually add on to the drugs? That's something that I personally feel it shouldn't happen.
I think it's easy to start and reply to your last question. I fully agree that I think one seizure once in a while is one seizure too many. And no one should put up with seizures. And, we should always try different drugs or could help that person. We should only give up on trying once we have gone through our bridges or we have burned our bridges. So I think that, yes, I would like to be able to make everyone seizure-free. But as I said, at the moment with armamentarium, we are only able to do this in about 2/3. So it's very important that we should find out what the person had before, try to see if there's other options. But this is something that it's very individual. You need to see how many drugs and where, and any reason why other drugs have not been treated. Now, moving to your first question. I think that when someone had, in the same family, two siblings have epilepsy, there's always the question, is this genetic or is this something in common? We know that people that have epilepsy are more likely than not to have other members of the family with epilepsy. Actually, although it's not always genetic, there could be other reasons. For instance, if someone lives in an area that is endemic for a bug or for something that can cause epilepsy, both persons in a family could be exposed to this, so that could explain it. If that has been ruled out and nothing else, you should try to see if there is a common genetic link between the two and if it's the same condition. At the moment, there's quite a lot of research going on, but most of the time we draw a blank. But like in the case of the brothers I mentioned, we were able to find a common cause for both, and the new treatment, which is not antiepileptic drugs, resolve their problem. But these are very rare cases. And in the future, I hope to see more and more of these as we improve our database, our understanding of what each gene does, and the cascade of genes that are probably involved in the sort of genesis of epilepsy. Now, the second question was to do with the comorbidity between depression and, well, you could argue that anxiety, depression could be a result of epilepsy. Indeed, anyone would get anxious. When will I have the next seizure? Anticipatory anxiety is a big problem. One of my friends say, I get very anxious if I know I'm going to meet my mother-in-law. But this is going to be more of a seizure. I'm very anxious when I'm going to have the next seizure because you never know. But there are a number of indirect evidence to suggest that anxiety and depression, they precede epilepsy. So we know that people with epilepsy have high levels, but both generalized anxiety disorder and depression are, if someone has a clinical significant episode of depression, they're more likely to develop epilepsy in the next 3 years. So we know that there is a correlation, and this is where I mentioned the spectrum. That's likely that generalized anxiety disorder, depression, seizures are going to be part of some functional spectrum. There's clearly a comorbidity, could be made worse by sometimes having seizures. Someone has done a job the whole of their life, developed epilepsy, then told you cannot do this anymore because now you have epilepsy. For instance, if you're a pilot or if you're a driver. So that could bring, but there are other indicators, as I said, that are telling us that it's also a biological basis. Anti-epileptic drugs, last part of your question. Yes, anti-epileptic drugs, they could be playing a role. We saw very interesting data yesterday from Monash, which was presented by our colleagues here, that shows that, yes, there's a number of cognitive issues that can result. They showed this very elegantly in a model that can actually result in cognitive problems. And we know this from patients. Sometimes, a patient has very subtle cognitive problems. You take them off the culprit drug and they get better. They feel more alert and you can see it. So I have no doubts that anti-epileptic drugs can be playing a role. But it's a multifactorial problem. There could be biological drivers, there could be the condition, and the drug could also be contributing. And it will be very individual. So you need to put it together for each person.
Is there any relationship between low blood pressure and epilepsy?
Not that I'm aware. I think that if you ask me, I would prefer to have low blood pressure.
Hi, Prof. I'd like to ask an opinion. Do you support in your practice, do you commonly de-escalate and later discontinue treatment for patients, say, seizure-free around 5 to 6 years?
I think that this, again, is a very, very individual issue. We know that we have markers for recurrence. Someone is on anti-epileptic drugs. But I always discuss this with my people I see in clinic. And at the end of the day, it's always individual that has to make the decision. For instance, someone that you had to use more than 2 drugs before you brought seizure under control, that's a very, very strong marker for recurrence. If someone had epilepsy, active epilepsy for more than 2 years before they become under recurrence, and they do not have one of these benign epilepsies that we know syndromes. If someone had myoclonic jerks as part of their epileptic syndrome, then you would probably be discussing with them, are you sure you want to come off the drugs? I think that in my experience it's very interesting. Females and males have a slightly different approach to this. Males are more likely to continue on the drug because as soon as I tell them, hey, do you realize that you will have to stop driving from now until 6 months after the last dose? That's it. While my woman patients are more likely to want to come off much quicker, and I suspect that often this is to do with the fact that mothers-to-be or mothers, they have a problem, concerns that this could cause a damage to a baby. And that's very clear. We see this after epilepsy surgery. Girls are much easier to convince, or they're more often driving coming off drugs than boys. And although I can't give you the research, my gut feeling, this is to do with boys like their wheels. If I had someone that has no risk factors for recurrence, everything is clear, been seizure-free for, let's say, 3 to 5 years, even if no markers for recurrence, there is still a 20% chance of seizures coming back. So It's up to the person to decide if they're happy to take a risk of 1 in 5. And I tend to ask people, do you play the lottery? Because, when people play the lottery in the UK, the chance they're getting anything back is 1 in 55. And if they play in the lottery, they're probably very happy to take the chances. If they don't, then it's a different discussion. But I think that each individual, you should have an individual discussion. I get very annoyed when I see someone, the GP, because it's a national guideline saying that anyone being seizure-free for X number of years should have a discussion about the continuation of drugs or coming off. And some people sometimes interpret this blankly, that people should come off. And I think that that's wrong. It needs to be the person who is going to have the side effects of the medication in the next seizure needs to be fully informed and then go away, think about it, come back, and then we take it from there.
Prof, there's one question here regarding biomarkers. So actually, which is the best site to get the specimens for the biomarker? Is it from the hair, saliva, buccal, urine, stool? Is there any research on the consistency on the result?
I think that biomarkers it's such a wide term, and a lot of people use it at the time. There could be all sorts of biomarkers. For instance, it could be imaging biomarkers. It could be, you could maybe have biomarkers that are in our CSF, in the fluid in the brain. There could be blood biomarkers. Most of them at the moment are unknown. There's quite a lot of research, the big consortiums trying to see if they can find biomarkers, why people do not respond to this. Are there biomarkers that will tell us that someone will develop epilepsy after a brain injury? I think that there's a lot still to be done. I can't tell more that here. There might be even some, in urine. Who knows?
All right. Any more? One more. Last one. I think it's...
Prof, you spoke about misdiagnosis is one of the problem of, and also a burden. I was just wondering what efforts has been made in order to overcome, is there any standard guideline to uniform the diagnosis test before you confirm this is epilepsy or this is not?
I think that, that's an instinct. Epilepsy is a clinical diagnosis. The test will only be confirmatory if you find something. So someone comes with a bona fide history of epilepsy. Most of the time the person won't be able to tell you. So what you usually get is a witness account. But nowadays we have a much better way of doing it. And I bet that all of you carry this excellent tool for the diagnosis of epilepsy. And it's called a smartphone with a camera. So there's really, when you see someone, a clip of a seizure, that's clearly a frontal lobe seizure, you have no doubts. You might not know what is behind it. Say this is really a frontal lobe seizure. So in my books, I don't need to do a confirmatory test because I like to think that I can do that diagnosis. We need to understand the EEG. It's a very interesting test. It will help us to confirm a diagnosis. If you look at the population in general, about 1 to 2%, they do have abnormalities in the EEG that are sometimes really bad. And I got an email today of someone who wants to be a pilot, never had a seizure, and has some spike and waves, and it turned out that he has a cousin that has epilepsy, which is well known that this could happen. Siblings and cousins of people that have some epileptic syndromes, they might have abnormalities in the EEG, but they never had seizures in their life. So the EEG will help you to confirm the diagnosis, will help me to classify the seizures, but it will not be diagnostic. At the moment, for instance, some syndromes, I would only want to do a diagnosis of Dravet if I have a genetic test. Then in that case, yes, I need a diagnostic test. But for the seizure, the symptom, I think the test will only be confirmatory. And I want to have a very bona fide, good history of seizures.
Prof, another thing is, I'm talking about head injury in childhood. And it could not be a severe or mild to moderate, but it's just, fall down from the bed. After 10 years, that particular child, when grown up, displays some seizures and it was diagnosed as epilepsy. What do you think the things which are happening in the brain? There are a lot of hypotheses and confirmation about neuroinflammation playing a role. What are the other factors and what could be the biomarkers to actually understand this?
Have you ever heard of a child that didn't have a head injury at some point? So that's the first question. So I think that it's very easy. As humans, we always try to find something to explain something. So it's a very common history. Little Johnny fell off the pram, but did he lose consciousness? Didn't know. But that is actually then interpreted. So in the majority of the times, head injuries, particularly mild head injuries, even with concussion, the increased risk is very small, probably negligible. There might be other episodes, and sometimes at some persons, yes, a head injury, for instance, repeated head injuries, people, heading a ball or American football, and that can start a process of inflammation that can lead to problems, and epilepsy can be part of that. But we are still in the infancy. We're starting to try to understand that. And it might well be that, and I'm a firm believer that inflammation is a big issue in epilepsy, but at the same time, inflammation is necessary for a healthy brain. So we need to find out exactly which way it goes and when and what trigger. And I suspect it's going to be the genes, the genetic blueprint, that is going to be playing a role and determine, who is at risk.
One last question, Prof. From a layman point of view, from epileptic patient point of view, from a caregiver's point of view, whenever a new drug comes to the market, for example, Fycompa is hype and everyone is looking, is this the drug which is going to cure us? What's your take on Fycompa? I'm sure Isai is not here.
Well, they know my views. I'm very open about what I think. It has a place for a few people, probably 1 in 20. And it's a magic bullet for them, the ones that it works. But my view is that if 20 million people in the world have epilepsy as a result of neuropsychosis, if I were to invest in basic sanitation, what has been expended in developing yet another new anti-epileptic drug, we're going to be having a bigger impact on the burden of epilepsy than a new drug. But that's a different discussion. I think that Fycompa is a drug called perampanel. It's the first drug that interacts with excitatory receptors in the brain. And it's a very interesting drug. Has very interesting side effects. But for some people, it's a magic bullet. Actually, people wake up on it, and you don't recognize when they come. The problem is they are very few and far between. There are not that many. And if I had a test that I could identify as early as possible, I would not have to go through a whole series of drugs to get to that drug. In my trust, in my hospital trust, I can only use this drug after this person has failed 8 other drugs. So if I had a test that can tell, hey, this person needs this drug from day one, I wouldn't have to try this person over years and 7 other drugs. See what I mean? So I think that pharmacogenomics could help identify those people that wake up when they get Fycompa. And they are there, I have no doubts. And I always say that a drug is only good in my books if I have a few driver's license, my patients get a driver's license. That means they become seizure-free. And I have some Fycompa seizure-free patients with driver's license. So I have no doubts it's effective for some people, but it's not a magic bullet.
But that's not going to happen.
Not?
That's not going to happen yet.
Not yet.
Not yet. I think we come to the end. I'm going to have to stop the session because time is running out. I would like to, firstly, definitely before I invite Prof Mahindran to the front, I think it has been a very fantastic and useful discussion. Really looking into the aspects of application, drugs, and also the present status of epilepsy. And I really hope that all of us have learned a tremendous amount of information and facts regarding epilepsy. I think not all is lost because, as what Prof Sander mentioned, with the advent of new technology coming in, now we can do a profile genome of each one of you within a day. So the new generation sequencing is really no big deal because before it used to take 15 years and $15 billion to actually do a full genome. Now it doesn't cost that much. It doesn't take that long anymore. So I think one day I really hope, and I can see it happening, that the personalized medicine in terms of pharmacogenomics in the area of applying our genetic content for the right medicine for it to be effective first time without having to go through all the area or without having to shoot in the dark. I think that's a very important because all these drugs, like it or not, have a lot of side effects. And I think you have to suffer before you get better. Sometimes you don't get better, you just die. Sorry, it's quite a worse scenario, but exactly that's what it is. The side effects are tremendous. So with that, I would like to invite Professor Mahindran, our Deputy Pro Vice Chancellor for Monash University in Malaysia. We'd like to show our token of appreciation for Prof Sander's presentation today. And we would like to invite Prof Sander to receive the presentation from Mahindran. Please.